have a panel that, together with Eduard, actually, mostly on completely on Eduard organization, and the aim, the purpose that we have today is to have more of a conversation. So it won't be particularly, at the appearance, it won't be particularly structured, because we're going to try to interact as much as possible. So my name is Silvia de Conca, I'm going to be the chair. And the panelists are today Robin Pierce, Associate Professor at Tilburg Institute for Law, Technology and Society in Tilburg. Aida Ponce, researcher at the European Trade Union Institute. Aviva de Groot, a PhD researcher at the Tilburg Institute for Law, Technology and Society. Heike Felzmann, from NUI Galway University, lecturer. And Scott Robbins, PhD researcher at Technological University of Delft. And then, of course, we have Eduard, postdoc actually now at Queen Mary. Sorry.
Thank you. Yeah, thank you everyone to be here. We will start with a definition of what are healthcare robot technology, so that we understand what are the robot technology that we are talking about. The European Commission said that healthcare robots are systems able to perform coordinated mechatronic actions, force or movement exertions on the basis of processing of information acquired through sensor technology, with the aim to support the functioning of impaired individuals, medical interventions, care and rehabilitation of patients, and also to support individuals in prevention programs. So I will start the panel just explaining why we are here, and then, as Silvia said, we will have different conversations among us. So one of the first reasons why we are here is because this technology is for good. Many times when we think about data protection conferences, we try to focus on how important it is to preserve privacy, etc. But sometimes we kind of think that the companies, they want to track your data and that they want to have a business model from them, etc. But actually, there's a lot of people trying to work with different information technologies that actually are trying to do good. So I think that this is a very important reason where to be here. The problem, it is true that the universe of these technologies is so vast that actually, unless we have a case-by-case analysis, most of the time we're missing the concrete issues that these technologies can pose, because although we are talking about technologies that they both combine tangible aspects, so the physical embodiment of the robot technology, they are also connected to the cloud. And depending on this embodiment, and depending also on the different connectivity that they have, because sometimes robot technology, they are also connected with ambient intelligent systems, etc., the issues will vary mostly. So when we have exoskeleton technology, we might be talking more about bodily privacy, also some issues about data portability, so how can you actually move the data from different robot technology, but also when we interact with robots, that they are a therapeutic tool, so when we are interacting with them in a cognitive layer, sometimes this bodily privacy might not be as important. The second reason why we are here is because legislation revolving around robot technology is a bit in a turmoil. On the one hand, we have some industrial standards that are trying to look into different robot technology, most of the times industrial robots. But the problem is that some of these standards, they do not cover collaborative robot technology or robots that they are not working in the workspace. Apart from that, we've seen recent standards that are trying to include or standardize ethical aspects into the design of the robot technology. But the problem of standards, as we all know, they have a problem of enforceability, and also the fact that they do not fix consequences for violations, right? In parallel of what the industry is doing, the European Parliament in February 2017 released a resolution stating their official opinion on what a legal framework for robot technology could look like. The problem of this resolution that then the European Commission answered later on is that sometimes it misses the bigger ecosystem of these technologies. So sometimes we are focused on the human-robot interaction and the issues that we have with that, but actually it is not only the user that is interacting with the technology, it could be also workers that are working in therapeutic settings or in hospitals, etc. The robot may be connected to different systems, so this is important. But then also because some of the provisions, they highlight some of the issues, so when you look at the care robot provision, they actually highlight the decrease of the human-human interaction, so they identify that as an issue, but many bunch of other issues are not highlighted. The third reason why we're here is because this is a very sensitive domain and very complex at the same time. So we are talking about elderly people, we're talking about children, we're talking about very sensitive part of the populations, and while we have been seeing different guidelines on autonomous cars or drone technology, there has not been that much effort on trying to understand like what are healthcare robots and what are the issues and like how can we mitigate them. So, said that, we're going to start with Robin. We're going to start explaining different examples of different robotic technology, and then apart from that, we will try to highlight different issues, and then all of us, we will be very free to interrupt in a kind way, step in. And also we completely welcome the audience also to just raise your hand if you have any question at any time. This will be focused on discussion, so like there will be no presentations of all of us, so yeah. So Robin, explain us a little bit about these robots that can help diagnose Alzheimer's.
Great, thank you. You can hear me, okay. Yeah, so I'd like to focus my remarks today on this increasingly more sophisticated ability to embed diagnostic capabilities into care and social robots. And so I'm going to actually ground my remarks in the case, a specific disease, a specific application of Alzheimer's disease. For those of you who, I'm sure many of you are somewhat familiar with Alzheimer's disease, but it's a neurodegenerative disease that erodes memory, takes away functional capacities, and ultimately results in death. Unfortunately, we have no cure. In fact, we don't even have anything that slows down symptoms. So one of the areas where there's been a tremendous amount of effort is trying to diagnose the disease earlier in its disease progression. It's called early detection or risk profiling, et cetera. There are a number of different ways to do it. And so one of the diagnostic tools that's coming onto the horizon in the form of robotic technology, smart robotic technology, seeks to identify Alzheimer's disease earlier in the disease progression. In fact, that's one of the reasons why it is often offered why we have no cure yet, is that we were actually targeting the disease far too late in the progression, and we need to start to intervene earlier. So the goal of this technology is to distinguish mild cognitive impairment, which is something that most people at some point in their lives develop if they live long enough. That just is a normal part of aging, from mild cognitive impairment that actually progresses to Alzheimer's disease. And so in the form of a care or social robotic or even as a standalone, which is actually now being under investigation, is the attempt to conduct different types of tests that would allow the robotic, and ultimately the clinician in the hospital, to diagnose someone who is at home with early stage, very early stage, possibly even pre-symptomatic stage Alzheimer's disease. So the ways that it does this, I think, are significant. The reason I chose Alzheimer's is because I think it's very paradigmatic in terms of looking at some of the issues that are confronting the use and integration, development, and design of robotics in healthcare. For example, standardized tests, cognitive tests that many of you may be familiar with, are now becoming automated and can be integrated into these robotics. These tests can be gamified, so it's actually fun to be diagnosed. They introduce new types of capabilities, such as mutual gaze, shared attention, monitoring of all different types. It allows the robotic to assess touch, dialogue, engage in sustained adaptive dialogue, assess drawing. One of the main ways that Alzheimer's disease is identified is that, for example, in the clock, where you're asked to draw a clock, say draw a clock that says 3 o'clock, and as you develop Alzheimer's, your drawing of that clock becomes highly impaired. And in fact, you can find examples of how this clock differs over the disease progression. This technology also would be able to examine your speech patterns, your pauses, the rate in which you speak, as well as your nonverbal cues, which are very integral in assessing dementia, Alzheimer's disease. And so all sorts of behavioral types of data can be collected in the effort to diagnose Alzheimer's disease. So as Eduard said, one of the issues we're looking at here is robotics, healthcare robotics for good. And so I want to point out the benefit. Well, the obvious benefit, the declared benefit, is the early detection. And I think their case can be made that this is not necessarily an unqualified good. The second advantage that it offers, and I think a very legitimate one, is differential diagnosis. There's many different types of dementia, many different types of neurodegenerative disease, and being able to distinguish one type of neurodegenerative disease or one type of dementia from the others can be a benefit if there is indeed treatment for the non-Alzheimer's type. Of course, with no cure for Alzheimer's disease, early detection doesn't really get us very far. And then the second part, which I think is critical to keep front and center in this discussion, is what is the impact of healthcare robotics in whatever form on health outcomes? And I think ultimately that's the crucial question that we have to reckon with as we go through this. I could go through a number of other types of technologies, the nanosensors, the drug delivery, et cetera, machine learning for different other types of diagnosis like diabetic retinopathy, diabetes, et cetera. But the bottom line is if I can just get some of the issues out at the start of this, is one, the scope. If all of these cognitive, behavioral, structural, biological, all of this data goes into making a more accurate diagnosis earlier in the disease progression, what is off limits? And so we have a purpose limitation concern, or not, as it's so wide. So there's a scope issue. There's an informed consent issue. Not only are we dealing with cognitive capacity, cognitive deficiencies, the fact that the scope of what is being collected and processed is under question. Diagnosis in the hands of a machine or machine learning is concerning. So you often see this kind of technology, certainly in the algorithmic form, described as clinical decision support systems. And that, I think, is a critical part, as long as it maintains a sort of meaningful role in the discussion, as opposed to, yeah, well, the doctor looks at it, makes his own or her own decision, but basically just says, oh, the machine says this, so let's do this. And as I said, the impact on health outcomes. The last point I'd make is cost-benefit analysis.
Actually, that's very interesting, right? Because at some point, one of the principles is the data minimization principle, right? So when actually you are at the very beginning and you're trying to build this system, when you are really trying to find out what triggers actually the diagnosis, etc., then you have to have this balance, right? Like between like how much data you actually need and what data not. I don't know like what's your opinion on this, but maybe if we could have these systems in a testing environment, maybe we could have some sort of testing, and then before it goes to the market, then we actually know actually what are the data that we need and what are the data that we do not need on having that.
Well, that's a really interesting question, and for the case of Alzheimer's, the number of factors that have been associated with diagnosis, more accurate diagnosis early in the progression, has actually expanded almost exponentially over the past 10 to 15 years. So still searching for a cure, there's almost a sort of built-in justification for collecting more and more information. And certainly that's basically the premise of machine learning, isn't it?
Exactly, yeah. Yeah, we'll be able to talk more about this. I also want to ask you later on like, whether you think that the new medical device regulation will also be helpful on this or not. Heike, can you explain us something about the Mario project that you just finished, I know?
Okay. Yeah, so I've been part of a project that tried to develop a robot for persons with beginning dementia. The purpose was not so much the diagnosis part, but more the purpose of assistiveness in relation to the cognitive decline, so everyday assistance, and in particular the social connectedness as well. And what we tried to do in that project, you said so much already about kind of the aspect of diagnosis and all that kind of information. So what we tried to do in that project was to realize some kind of value-sensitive design process within the limitations of funding and the limitations of an international team as part of a Horizon 2020 project with many partners across Europe. So not everything that would have been ideal was actually realistic in that context. But yeah, so I'd just like to say a few words about that process. It's not just about privacy. It's kind of the slightly wider aspect of really how can you realize a realization of values in relation to that project. So we started out with the development of an ethical framework tailored to use cases, and those use cases were developed on the basis of quite extensive consultation, both with the professionals as well as with persons with dementia and family members, professionals who would be working in the pilot sites, to get a sense of what kind of things actually mattered in relation to a robot that could provide some degree of social connectedness and some degree of assistance for everyday life. So the ultimate target was something that could be used domestically as well as in care home settings. So we developed that ethics framework and then tried to see how can you make that useful for practitioners, in particular for a multidisciplinary practitioner audience. So we developed checklists on the basis of that framework and those use cases for different types of stakeholders. So it was partly about how do you realize that research process with the pilot sites. Who do you need to prepare? How do you need to prepare the pilot sites, the professionals who will be working with the robot or who will be affected by it, family members who might be informal carers or just family members, users obviously. And we also try to involve the technical development side. And so we got stakeholder feedback to see did those checklists address the things that needed to be addressed. And then the pilot process of having, which was a stage process over several variations of the robot, it was accompanied by a qualitative process of data gathering, both from the stakeholders in terms of forms. So we had ethical encountered issues that were captured by the people in the field whenever there were issues they felt merited the label ethics. So those were, a lot of them were about consent related complications, but it was also about distress and management of those kind of complications. And so we tried to analyze what the people in the field actually identified as issues. And we also did afterwards qualitative interviews with stakeholders, so the researchers in the field and professionals who had had contact with the robot, to see how did they feel their concerns that they might have had initially realized, and what happened. And and so those stakeholder interviews happened then post the trials. And we try to look at kind of values in a kind of wider sense. So what we identified mostly really was in terms of the initial stage, there was a lot of concerns around the replacement of healthcare workers by robots coming from the nursing staff in particular. So I think we'll be having that issue addressed later. In terms of family members, that was also an issue that came up, that they were worried that what would happen is if there's a robot, it'll just end up not giving the care that their family members needed. In terms of what happened during the process, the main concerns that arose during the process seemed to be more related to issues of informed consent. So it was the complications of having a process in which both the formal and informal carers and the user themselves were giving consent, and the user with limited capacity, fluctuating capacity. So to find a way in which you could realize a meaningful consent process in which everybody had a voice. And so conflicts of interests between different stakeholders played a role in several cases. So where maybe the person with dementia was quite happy to be involved, but maybe the family member wasn't, and so how to manage those. Or where a person who didn't meet the criteria was really interested in participating. And so that was discussed and kind of managed on an individual basis. In terms of the stakeholder interviews afterwards, we were looking at what did people feel about using these checklists. So checklists, you always want to avoid tick box approaches, but at the same time, tick boxes can be quite useful for at least checking, have you addressed a number of those kind of relevant issues. And so the feedback we got on those was quite positive. There were some issues around, well, was it maybe too much in some respects? Was it targeted enough or specialized enough to the very particular case or the very particular environment of the pilot sites? So kind of the adaptability to the specific needs was one issue that came up there. I'd say I'll leave it at that.
Sure.
Don't take up too much time.
I think that the good thing about what you're saying is actually that there's so much more people involved in the robot environment than just the user and the robot, right? Like sometimes we just have our focus on the patient and that we want to take care about the patient and so, but actually that there's a lot of people out there, right? I want to know more. I think that now I will leave the floor to Aida because Heike highlighted that one of the concerns that actually the nurses had were like their replacement, and there has been a lot of discussion on whether workers are going to be replaced or not, and this also touches healthcare environments, right?
Yeah, actually, I would like to bring to the discussion an actor which has very much been overlooked when we speak about robot and human interaction. And it's the practical aspects that happen at the workplace, in any sector. And today we're speaking about the healthcare sector. And here we're speaking about all sorts of professionals, whether it be doctors or more technical staff, to physiotherapists, nurses, care workers, all sorts of workers that are active in the healthcare sector. So how they interact with a robot or an AI system or with an algorithm, it poses two questions. So the first one, and which has been highly debated actually politically, is, are robots going to take out our jobs? And different studies have portrayed different approximations and estimations, whether it be the study from the OECD, whether it be studies from Frey and Osborne, and both of them explain that some sectors are going to be affected, that yes, some jobs are going to be lost, but we don't really know to what extent professions are going to disappear. Interesting, speaking about diagnose, perhaps that profession that might really get a deep transformation will be diagnosed. People who do radiologists, who work with imaging, they might face a huge transformation, because obviously machines can have a better eye in comparing images and, for example, identifying if a cell has a tumor or not. But okay, that's another discussion. Today I want to focus on the other side of the coin, which is those professions that are going to be still there, but of workers who have to co-work with an AI system, with an algorithm, or with a robot. So this is very interesting, because my research question is, what do we do with that? How do these workers have to interact? From the organizational perspective, from the company perspective, there has to be some sort of organizational changes. How, and the questions here are, what is the risk for the worker in working with a robot? What are the emotional and psychological adaptations that the worker might need to do when working with such system? And we need to clarify then the tasks and responsibilities of the human worker. What is my role now with regards to an algorithm that has to make a decision together with me, for example? And I have an example, a very quick example of what happened in particular with nurses. So there is this very interesting robot, Apotheca Chemo, developed in Turin in a hospital. It's now being used widely in more than 30 countries, and this robot is helping in the pharmacy to make very specific medications, like drugs to cure cancer, chemotherapy drugs. These drugs are very complicated and very complex because they are hazardous substances that normally nurses need to handle in a very safe and enclosed system. They need to be very precise so they can tackle the cancer in a very precise way and do not damage the patient. And the dose have to be very, very accurately measured. So a group of researchers developed a robot that could do this measurement and handling more efficiently than a human hand. In this case, in order to develop this robot, the team of researchers asked the nurses and the staff of the technical staff to co-work with the developers in order to identify those crucial issues that the robot should need to be careful, and to identify also the errors that the robot was making. So from the beginning of the development of the system, not at the end, which normally happens with other products. So in this case, the nurses were technical human factors. They were not acting nurses as such as in the past, but they were correcting the system and trying to make it better. So we can have this positive example that they were involved from the beginning. One thing. The second thing that I would like to highlight is that the role of the nurse did change. So the question here is for you and for the companies that you work with, or for your research question is, okay, so if we need to change professions, if we need to be digitally aware or algorithmic aware, so what are the skills that we as professionals, nurses, doctors, or technicians, physiotherapists, we need to acquire in order to tackle this digital profession, work environment. And this is a huge, the e-skills or the digital skills is a huge agenda. This is discussed in the European Commission. We don't know exactly for what profession, which skills do we need to adapt, but it's something that in your research or in your work, we need to start to work with. So I leave you with this very first example.
But this is very good because like we are bringing to the fore like very important things. Like first of all, that the issues that we need to take into account are impacting different people, not only patients, so also workers. One of the things that I was talking the other day with a friend of mine, he's an ophthalmologist actually, he was telling me that now we have this software in the hospital, and for 4 years now we have been following all the software and like putting the marks and giving all the information. So actually like the new roles of nurses and doctors actually is most of the time helping this system to be better, right? So I have the question is that who is going to be enriching themselves with this, right? So like on the one hand, we will have a better diagnose or a better outcome of the machine, right? Like to cope with this scope that you were telling before, but at the expenses of the knowledge of the people. But actually, like they are not going to be kind of rewarded. Maybe most of the times they are going to be replaced, right? And who is going to be replaced? This is also very important because as she was highlighting, another friend of mine, he's a radiologist, and actually he was very worried that IBM Watson Oncology might replace him very soon. So we will have tools that might support the general practitioner, but that actually they will replace other ones. And this highlights another important issue here is that it seems that not only unskilled workers, cashiers in the supermarket, but also highly skilled workers are going to be the more and more displaced from their work. And this is a very important issue when we think about healthcare robot technology on this, right?
Sorry, just a quick thing about that.
Of course, Scott.
We're talking about highly skilled workers being replaced, and I've heard we're going to have better diagnoses. And I want to qualify that a little bit because, yes, I think algorithms, especially machine learning algorithms, have been shown, to detect cancerous moles, for instance, to be better than your average doctor or better than a group of doctors. However, when machine learning and processing all this data, when it gets it wrong, it gets it very wrong. We can think of a couple of examples like Google labeling Black Americans as gorillas, and that's something that we have to be very aware of, that there has to be some meaningful human control that questions, that isn't put in the ability to, in a position able to challenge the machines and the robots making some of these really intense moral decisions about patient safety or patient diagnoses or medication. And in the medical world, there's an example that I just heard this morning about a machine. There was a glitch, they called it, that prescribed 30 times the amount of medicine that was supposed to. And this guy ended up in the ICU for 7 days due to it. He luckily did not die, but that's a situation where we clearly overtrust these machines and these robots. And data has gone a long way to aiding us, but we have to consider it an aid and ensure that there's somebody with the knowledge back there that's going to check this work.
And in fact, Heike was kind of already highlighting this, right? Like this life cycle process and protection and checks, right? That maybe now with the GDPR, like for privacy, but then also with other aspects, will be the more and more put in place, right? Like, so the importance of not only do these checkups like at the very beginning, but also like throughout the whole process in this, right? Aviva, please.
Yeah, I'd like to say something here, but I think all of what we're saying here, of what you're saying, actually makes it very clear that it is a complicated business of embedding a machine into an established care circle relationship with trusted delegation systems that are very much based on human interaction. And I think my study focused on social robots in what I call the peripheral sphere of care. It's like, this is the sphere of care where we're not talking about medical applications, but we're talking about social functions. So like you were saying, supportive, assistive, also entertaining functions. And what you see there is that these social robots, their functioning is based and dependent on our human inclination to anthropomorphize. So we project human emotions, human behavioral traits onto these machines. And what happens then is that we treat them in ways that we are used to treating the people in these care circles. So what I found, for instance, and I focused on privacy issues that arose specifically from this human-robot interaction. Instead of just seeing the robot as a machine that collects data, so moving away from the more straightforward data collection problems, I found that, for instance, medical confidentiality is a system in which the trust between a patient and the doctor, but also the nurses, who have a very specific task of understanding why a patient discloses and what he discloses and why, at what time. This system is influenced by robotic presence because people are known to disclose more and disclose other things to robots. What I also found that the social reactivity of these robots makes use of exactly these technologies that we've been seeing at this conference. We could call them by now acknowledged troublemaker technologies. And we don't understand human-robot interaction well enough to understand how humans deal with robots reacting to them. Data is collected with use of advanced sensors, either through wearables, but also facial recognition and speech recognition. This actually creates information, or information is created from this, that is not actively and consciously disclosed by the patient. What I also see is that when these technologies are then used to assess the information that they gathered, which are the algorithms and the AI that we've been discussing so much this week, this information or assessment on the emotional state of the patient is fed back into the patient. And the patient will adapt his behavior again to the robot, because that is what people do. And to just one example to illustrate how we don't know how this happens and how to control it is that we, for instance, been building aids for soldiers to protect them from harm. And one beautiful example is of a mind-diffusing machine which had 4 legs. We see this in all the language you use about robots. And the operator of the machine was feeling very bad because the machine was operating on his last unsacrificed leg, and it hurt him to see this happen. We also see soldiers ready to risk their lives for what they would call a dog carrying their equipment.
So human-robot interaction may make us rethink certain concepts, right? I think that Silvia has some insights on that, right? Like on how, yeah.
I just add something about the displacement, though, not much about that.
Do it.
I also wonder from a larger perspective how we are dealing with that, how we're gonna deal with that, because as we were saying, it is also a matter of creating new skills. And so to me, this means that it is a matter of how dynamically and how quickly the state can change the formative offer. The boards and the ministers of education can meet that. How quickly we are to respond to that as a society. So I do think that displacement might very soon turn into a question of our educative systems, especially, for example, from the university perspective, have been the same for centuries now, with very little change. And how are we actually going to make that way more flexible to respond to this kind of technological change?
Yes, if I may, I'd actually like to respond to the last 3 speakers. Aviva, I think you make an extremely important point when you talk about, you're coming into a context of human-human interaction. And there are indeed, I think, which often gets overlooked, a system of medical ethics norms, of healthcare norms that are pre-existing in this context. And so you're not coming to this context with a technology that needs to define new rules. There are certain rules that are already there. And because of that, Scott, your concern about the algorithm or machine learning technologies operating independently, making diagnoses, for example, independently of the physician, is already being addressed. For example, the FDA has recently, in the past 2 weeks, passed draft guidance for how algorithmic information should be regarded in the clinical context. And it says, among other things, that no diagnoses, no type of medical decision can rely exclusively on the algorithm. So this is very much embedded in healthcare norms, and this is already being addressed. And the one last point,
Of course.
I left out Silvia. So Silvia, the workplace, and Aida, actually, your point initially, one of the things we're talking about is why are we bringing robotics into the healthcare field? And one of the reasons is because of a shortage of trained personnel. And when we look at the age demographic, the changing age demographic with increasingly more elderly individuals who need or want to remain at home and need assistive help, then we're not necessarily looking at replacement, but complement or augmentation. And how that balance is sort of carved and how we actually carve that solution, innovation, I think will really determine.
So if we have shortage of trained people and then you want to have humans in the loop, how we can do that, right? I mean, this is the paradox of this. So I think that you did a very well point that at the very end, there is a lot of discussion on like how we can keep the human in the loop in different decision-making processes. And actually the problem is that if we have a very short amount of people that they are trained, and that the more and more these algorithms are going to decide on their own, and they're going to be much perfect, etc. The problem that I see is that I don't see maybe humans having the capability to then like making a meaningful contribution to this, right?
Well, yeah, if I may say something about that, there was a recent project started where robots were designed to help out in groups of mixed dementing and non-dementing patients, and they were specifically meant to create algorithms to deal with crowd control. And this project had problems with data protection regulation because like some people were had consented, or their family had consented to their participation, others had not, just like you said. But what also was problematic was that personal stories of some of these patients were then used to, when they were seen to become restless, go to them and start maybe giving some childhood memories back to them so that they would be restful. But then the idea was also that they could use these memories to try on other patients. And what was said to me was that, listen, people do that too. Like if we have a nurse, she would do that too. She would test things that worked with one patient on another. And I would like to say that this is a completely different system. It's a trusted human system of confidentiality. A patient will trust the nurse to understand what to disclose, what not to disclose, what to use, what not to use. Nurses have a very prominent moral responsibility here. We should never try and delegate that. And I also think that, I think what Scott was saying, that we trust machines quite easily and too much. And I think as a nurse, I would not be happy if this happened.
Just one note on the keeping humans in the loop, because I think even though there's legislation and there's wording surrounding that they should always be, and it shouldn't always only be up to an algorithm. I think of the Tesla, for instance, putting it in its terms of service that you have to stay, attentive during the entire trip, even if you're on autopilot. But I think we know in practice that doesn't work. If you're driving around and the machine doesn't make any mistakes for a long period of time, you're going to take your focus off the road, and when something bad happens, you're not ready. And I think in this case, language can be extremely important. How we describe what the robot or machine what their function is, what their purpose is. So are they making a diagnosis? You know, the diagnosis, the machine has diagnosed the patient with X. Now, we could just say meaningful human control is a doctor checking, signing off on that. Or is it the patient has speech patterns associated with a heart attack? That's a very different situation, and the language is such that, well, we still need a human to say, well, along with everything else, you know, I conclude X. And that's one way to help, at least, with keeping a human in the loop.
Heike?
Maybe just a very quick comment on that. I would be worried that the labeling itself won't do that much of a job, because as long as the machine is doing certain things, people start relying on the machine to do certain things, no matter how you label it, potentially. But
right. I think it matters. But yeah.
Another quick point there in relation just to the nurse and confidentiality. That was actually a point that came up in the interviews, that nurses were worried that just like us when we looked at the data protection side of things and the confidentiality side of things, they themselves mentioned that they were worried that what the robot would do would be disclosing things in the wrong kinds of circumstances or give information away. And that was also something that the patients were concerned about. So privacy issues didn't play that much of a role from the patient side, but one of the things that did come up was the issue of, will it tell others about the things that I say? In practice, then, in the end, that didn't turn up to be too much of an issue. But the confidentiality from the professional side of things certainly.
And I think it would help, actually. We've also been talking about privacy by design and by default. And I think it would help, actually, if we would at least try and understand that it's a value to make our robots behave as obvious as possible. I mentioned this as well, like there's a value for a ruminating robot who will constantly tell and show what it is doing. It would, for instance, say, oh, you're telling me about your childhood. Is that a secret, or do you want me to share the nurse? Or, oh, you're telling me you're feeling bad. Do you want to tell this to your doctor or not? It sounds a bit childish, maybe, but I think it's important that we don't design this away so that patients get to understand what the role of the robot is in this social system.
Maybe just quickly to that, if you look at the target group of persons with mild dementia, for example, that could then become a challenge in creating too much cognitive overload. So for us, that was it was a real issue to balance, let's say, transparency concerns and to balance kind of.
But that's where medical law
concerns.
comes in, right?
Yeah.
This would help. And the sphere that I looked at was underregulated because it was seen as a peripheral sphere, not a medical sphere, but just social fun. I think this is what we have medical laws for and medical ethics.
If I may I also add something? There is also, I think, there might be another aspect too, because I've seen researches of healthcare robots to help the patient keep up with the medicine intake and to keep more or less an eye on the situation of the patient at home. And it was used with elderly people that didn't have necessarily dementia, but that, for example, had heart conditions and tended to risk to forget the medicines. And the results were actually very disappointing because, so since it was elderly people, the robot was set on a volume that was quite high. So when the robot had to remind the patient to take the medicine, the volume was fairly high, more or less like I used to talk to my grandfather, I guess. and they deactivated that function as soon as they understood how, because they didn't want the neighbors to hear that and understand that they were not exactly hearing well, or that they were sick and they needed a certain medicine, and they felt embarrassed. So there was also, as I always say, this is healthcare. There is also the care part, and the care part has a lot to do with dignity. And I was also in the other panel on AI, where they were discussing how the moment the robot does not consider certain kinds of emotion or has a goal that is different from ours, the dignity, ethically speaking, might be injured. So
No, then I will say something on this, because like the problem is that then like because you have systems that they are personalized, and then because this creates an emotional reaction to the user, then the robot needs to adapt to that emotion. Then they are emotionally intelligent robots that adapt to the user, etc. And this is all growing data that is being collected, etc. Right? Aida and then Robin.
Yeah, and linked to that case, what happened on the other end? You pointed out the relationship between the robot and the patient, but what about that sometimes doesn't really work? What about the relationship between the robot and the worker that sometimes doesn't really work as well? So for this case, I have the example of the power suit, an exoskeleton that helps the workers to lift heavy weights, whether it be physiotherapists for the healthcare or nurses again, but also in other sectors, in construction sectors, obviously, lifting heavy weights. And for those workers who have to look at the ceiling and paint for long hours, so they need to support their necks and the back spine. So what happens here? Sometimes the exoskeleton is not fit for purpose. It doesn't really go to the well-being of the final end of the worker, in this case, for example, which is alleviating the stress of the work and doing the work in order to avoid musculoskeletal disorders, back pain, and other chronic disabilities in the future. So in this case, the power suit, which is also very famous, some researchers in Johns Hopkins in the United States studied that from the worker perspective, wearing this exoskeleton showed discomfort in wearing it because it had some pressure in certain parts of the body of the worker. It also changes or shifted the center of gravity, so that triggered a little bit the balance of the person. And a very important issue is that exoskeletons are not really fit for the bodies of the men and women. Sometimes we have different shapes and forms, and not because doing a small size fits the body of a human with larger hips or breasts on the front. So these are also limiting factors that should be also taken into account from the wearer perspective, in order to see how can, from the technical point of view, they can be designed also in a safety way, safe by design, which is also another aspect of the coin.
Sure, and also I think that the industry was very happy because there was this new, in 2014, standard on personal care robots trying to govern some safety issues into the exoskeletons. But the new medical device regulation is saying that those devices that have the medical and the non-medical device condition, they will have both to cumulatively comply with the medical device regulation. So like maybe this is one of the good things of this regulation, that actually like even if these exoskeletons are going to be used in industrial environments or in for rehabilitation purposes, we will have like a stronger measures in this case. But this is very interesting, and also maybe new technologies concerning like 3D printing, etc., like can help to the personalization of this, because actually like the good thing about some of these technologies is that we can deliver personalized care. So I think that this could be also good. Robin.
Yeah, I wanted to basically pose a question to Silvia regarding the example that you used that I actually was not familiar with the problem with compliance, taking drugs and not complying. Well, we know that non-compliance, non-adherence to medication is one of the main reasons why for poor health. It's not because they aren't diagnosed, it's not because there isn't a treatment, it's because people don't take their meds. And so the question is in fact, there's another technology that's been introduced to address the same problem that you've brought to some of our attention, the nanosensors that basically are taken internally and radio back to the clinic, to the physician, whether or not you've actually taken your medication. And so I was wondering, do you see a similar sort of dignity issue? I mean, there are obviously privacy issues, autonomy issues here, but do you see the same kinds of dignity issues or similar, both privacy and autonomy issues for these? And would fixing the voice, the tone of voice, address this? Can we get it right, I guess is my question.
Yeah, that's a big question. As per fixing the tone, that was one of the measurements that were taken then to try and correct and adjust the devices. And if I find it, I'll gladly share the research report. And but in general, a lot of issues in terms of surprisingly, a lot of issues in terms of elderly people not wanting to share, even just not wanting to explain guests that were coming over why they had the device for in the bedroom or in the kitchen, were also raising. As per the nanotechnology, I also read the news, and the FDA actually approved even the pills with the nanotechnology in it. I do see a huge dignity issue there in terms of autonomy and agency. And at that point, the way I see it is the choice that we want to make as a society. In terms of, do we want to protect, it's the same with kids, to be honest. It's the same issue I'm also having now that I have to give the warming pill to the cat, and the cat doesn't want it. We have to, it's true, we have to choose whether or not we want to, which interest is actually heavier on the scale in this case, to be honest. But this is a public discourse, this is a general discourse.
What does the audience think about all these topics? We have been talking, and also during these days of the conference, like, is anyone interested in sharing some issues or worries, or is anyone willing to share some solutions of the arising problems?
Hello, I'm Diane Whitehouse, and I'm here from the European Health Telematics Association, which is based here in Brussels. I'm going to ask one provocative question, and the other one I'm going to ask two of you to interact, because I'd be interested in that happening. So I recently went to a meeting held at the Royal Society of Medicine in London, and it was about ethics and robotics in the healthcare professional setting. But actually, I noticed that the kind of questions that the participants were, or the concerns that they had, were more to do with cost, high cost of the robots, weight of the robots. So apart from the very tiny mini Japanese style or the animalistic style robots, so they were concerned about weight, they were concerned about movability, manageability, so very practical, cost effectiveness, very pragmatic, very practical issues, as opposed to, maybe Robin might say, the ethical issues, because they have thought some of these things through. But I just wonder whether that insight into a meeting, not just among clinicians, but among a wide range of health professionals, is surprising to you, or how you would react to that. So that was part one. The second part was, thank you to Aida for having mentioned the Locioni Italy Apoteca Chemo case of co-design with nurses, which I think is a fascinating example. And I'd be interested in an interaction between Aviva and Aida about, practically what one can do in a work or in a home setting with regard to training and development, an ongoing understanding of the robotics. Thank you. Oh, Ronald.
If we can take the questions and then we will have the set of answers.
Okay, then Ronald Leners, Tilburg Institute for Law, Technology and Society. But a question to the entire panel, I guess. And I want, on this late Friday afternoon, I'd like to try and get the forum a little bit to data protection, privacy and data protection. And the question is the following. A lot in life is about framing. And many people in the data protection domain look at the data collection and the interaction of robots with patients or people from the perspective of data protection. But we're also familiar with doctor-patient confidentiality. What would happen if we frame the interaction of robot with patient in terms of robot-patient confidentiality? Would that change the design, or would that change the whole debate on what is important and not in the interaction and the data processing, or doesn't that make any difference at all?
I think there was another question if we can take. I think he was first.
Thank you very much. I will follow up on a more technical level. At the end of the day, these robots do process through the sensors an enormous amount of data. And because the GDPR is a technology-neutral regulation, it means that at some point, the issue of their compliance will have to be addressed. I have a provocative question for the panel. Robots that deceive for beneficial purposes. Practically all healthcare robots do have an improved effectiveness by adding and incorporating deceptive features. This is, at the end of the day, this is exactly what we do with somebody we care about and who is terminally ill. We are not going to tell a beloved one as he or she exits a chemo session that she looks ghastly. We are going to deceive him. Now, how do you structure them under the GDPR? You can use legitimate interest. Good luck with the balancing test. We have tried to do that. The first draft ran into 80, roughly 120 pages, and it was not conclusive. You can use consent. Well, under consent, you will have to tell somebody that you're just about to deceive systematically, that you are going indeed to deceive him systematically, and you will also most likely have to tell him in detail and in granular detail how you're going to deceive him. It could still work. In deception theory, it's called the theory of outs. So there are ways to continue to deceive a mark that is aware of the deception, but it's normally difficult. So under the GDPR, in a more technical way, how would you model this? Thank you.
I think we have one last question.
Okay, thank you. Guido Dorodiega, Northumbria University. Just a brief comment on job displacement and education. I'm a teacher, and so for me, one of the main things that I try to teach is how to interact with technologies and how to do it critically. So I think one way to prevent job displacement is this, really, to teach how to be critical with regards to technologies and how to interact with them. And a question is about ethics by design. So because you mentioned a number of ethical values such as autonomy, dignity. So to what extent can ethics by design, implementing ethics into the design of care robots, be an answer?
That's a lot. We have, I think, slightly more than 10 minutes, so if the answers can be very on point. I'm going to be last because I'm the chair.
I think
Sure.
I can start answering one question.
Go.
And completely then give it to you like you asked us to, and then through Scott. I think I have this last time. No, I just wanted to say about the robot patient confidentiality that Ronald mentioned. This is actually something that I think is a very good idea, but not simply because it's a good idea, but I think a patient has a right when he starts confiding in a robot that is put next to him as a social assistant, he has a right to that confidentiality like he has with the nurse or anybody else that is in the care circle. I think the problem here is that the robots are put specifically with the patient to provide some care that the care workers that we don't have enough of cannot provide. So there will be a lot of interested parties in these exchanges. I think it will be hard to get complete robot patient confidentiality without deciding better than we do now on what is the role of the robot. And I think this is a problem we need to solve, but I think that's a very good point. I also think that this goes to how are these discussions going? I think we have a very badly informed debate at the moment. We have companies that are completely exaggerating what they can offer, while robots that they actually offer do not have the capabilities that they say they will have. But we also have robots that can actually do a lot more than we think they can, simply because they look so simple. So I think when these robots are presented in institutions, that there might be too many questions asked or too little, and I think this needs to be a better informed debate. I'd like to ask you about what you think about that.
Okay, thank you very much for the question. I appreciate it. So concretely, what to say in training and developing robots at work? Two things. First of all, yes, robots are introduced in a company because they are more cost effective. That's the logic behind it, and they will replace a human hand, perhaps. So in introducing, and secondly, robots in the industry, in any sector, have been there for many years. So we have been looking at this overcoming of robots for many years, automotive, now healthcare sector. But now, since we are very much aware of this, from a company perspective, in a company, my advice would be to involve the staff very much from the beginning to see, okay, we would like to have the idea of introducing a robot. In your view, what organizational change we need to do in order to not avoid replacing or trying to understand how can you do your task better, training the staff. Secondly, allowing the staff to choose the better model of robot that could work or co-work together with them and see how these models work. Secondly, organizing the logic of the robot, involve the staff that is going to work with that piece of technology to see how can this be adapted to work with the staff. And thirdly, introduce also the feedback loop from the staff into the development of the system. That's very important. It's not only a finished product that is put into the workplace and it's done. When it implies a developing of an ISO standard or a CEN standard, then normally what happens there in the technical committees is that only developers from all the countries sit down and discuss technical issues. But it's very important to say that there is an opportunity for having observers like workers who have non-technical issues to say something about that and to have an actual input in the development of the standard. So in doing that, we can ensure that the standard is not only a technical document without any ethical component or moral component or social component or other type of component. So having a representative of a worker in the standard committee, it works. I bring this example from the machinery industry, when tractors fall off and then the driver has to come to the technical standard and say, hey guys, if you don't fix this, the tractor won't work. That's my experience as a driver. So bringing this example to the technical sector, to the healthcare sector and other sectors is valid. So very quickly, that was my answer.
I would also say that I don't think that it is any surprising the fact that the concerns were related to the weight of the robot and the cost, because actually that is a problem that we all know. Actuators are very expensive, they are very weight, etc. So like most of the times, like they are very costly, so like they cannot be assumed. When an exoskeleton costs 200,000 dollars, like it might not be accepted like in a healthcare facility. People cannot develop fundamental research with that, etc. So like by lowering the cost and the weight of the robots, especially using cloud services, etc., then you can actually have that. I think that is more a market thing. I'm not sure, like, or what I'm astonished is that it seems that the ethical discussion or legal discussion, like, it's kind of solved, and that the concerns were more these. I think that we need more guidance on the legal and ethical aspects on this. Just another quick comment, and then Robin and Scott. Is it totally true, actually, what you mentioned before? We have already a Pleo. Pleo is a dinosaur, a robot that actually, it does not comply 100% with the rules of the robot. So actually, like, each of these little dinosaurs are different. And in a very, very recent publication, 2018, I don't remember now the authors, but they were actually saying that the problem with robotic technology, especially with autistic children and also with neurotypical developing children, is the problem is the engagement, right? So they need some solutions for that. So like first they personalize the system. Then, as I said before, then they realize that there are like some emotional reaction. They need to adapt with that. But actually, like what we realize is that what could actually make more real and alive the robot, it is if the robot does not actually comply 100% with certain parameters, which that highly complicates or makes much more difficult also the certification process, right? So like when you have a standard and then when you want to certify a standard process, how are you going to be when all these machines are going to be a little bit unique, right? Yeah, these are like my two comments. Robin, Scott, and Heike.
I'll be extremely brief.
We have 5 minutes.
Okay. To address the first point that was made about the inclusion of cost effectiveness in ethics, I think that's an extremely important consideration. My last ethical consideration that I mentioned was cost-benefit analysis. And in the particular case of diagnosis, I think that that's more important. What benefit is yielded by this intervention when you consider in light of the cost? Whereas the cost effectiveness, does it achieve the goal that it's supposed to do? Does the technology do what you intended to do? And that may be true, but it doesn't really help us in improving health outcomes in this particular case. The second point, in response to your provocative question, Ronald, about robot patient confidentiality, I actually disagree with you, Aviva, on this. And I think it goes to the question of accountability. If you can't really hold a robot accountable, and I'd be concerned if we shift from doctor-patient confidentiality to robot-patient confidentiality, what happens if that confidentiality is breached? So if we place either the physician or the hospital or some responsible entity in the position of being accountable for maintaining or securing that confidentiality, then I think we get a lot further in terms of addressing our concerns.
Yeah, I didn't mean to shift it from the doctor to the robot. I just meant that the robot in that case should be like a dinosaur with no robotic interns at all, simply just not being able to disclose whatever it said to them. Scott.
Right, really brief. I want to just say something about the deception. I think there's an easy solution maybe from an ethicist, but I think that if the robot is put into a position that they are deciding to deceive a patient like a doctor would, then that shouldn't be done. That shouldn't be a situation that ever arises. We can't delegate such a moral role and task to a robot that can't accept moral responsibility, accountability, and all that. So I can't imagine, maybe I'm not, lack of creativity, but I can't think of a situation when that would be justified. Number two, I just want to talk about ethics by design really fast, because I think one way we can achieve some of these values by design is by talking about the scope of the tool that we're using. So in robots, all these sensors are being placed into these robots, but I think we really need to assign it a function, a purpose, and then what do we need to achieve that purpose? And we really need to go backwards instead of using a multi-purpose robot with a bunch of sensors throwing in there and collecting all of this data, especially when we have security issues and And the NSA can't keep their data safe, so we're collecting all this data, and we're really compromising many values. So that's my really quick version of the scope.
I was thinking also about placebo. Like, I don't know if there are like guidelines on how to use placebo or not, but...
Can I add very briefly something about that?
Of course.
As far as I know, the law does not really allow the doctor to deceive us. This is not like Dr. House does not exist in reality. When a doctor deceives us, he's... The relatives, yes, the relatives, I understand. But, you know, if we are using these as healthcare tools, we have to let them abide to the standards of the doctors and the nurses and the personnel that is formed for that. And as per the relatives and the ones that are in the house, well, I guess that's why they're insisting a lot on researching emotional recognition for them. But I'm not a big fan of it, honestly. I wouldn't think, as it's not a good idea to use them in war robots, I don't think it would be in healthcare robots.
If, just really quickly, just occurred to me when you mentioned that, I wonder if we can find a helpful parallel in considering placebos, which are authorized as a form of deception. That may be one way to look at it. Yeah.
Perfect. So this is the end of this panel. I'm very happy actually that we managed to have a discussion. That was the idea, just have a discussion among colleagues on this and not have like more presentations. I will just read a quote that I really like just as a final message, and then we can upload to the panel. It is from Weizenbaum. It is from 1972, and it says, "What is wrong, I think, is that we have permitted technological metaphors and technique itself to so thoroughly pervade our thought processes that we have finally abdicated to technology the very duty to formulate questions. Where a simple man might ask, do we need these things? Technology asks, what electronic wizardry will make them safe? Where a simple man will ask, is it good? Technology asks, will it work?" Thank you so much.